And remember to record. Okay. We are super excited to have Jessica Bryan and Amanda Mendenhall with Southwest Behavioral Health Clinic, right? Okay, I was like the C, I think is clinic. Center, there we go. Sorry, I couldn't read. Thank you, Jaden, for helping us get us connected to Jessica and Amanda. And they're going to be talking about assisting victims in crisis and substance abuse. So we'll talk about this. And you too, just making sure it was one. Yeah. Hey.
All right. Hello, my name is Amanda Mendenhall. This is Jessica. We work for Southwest Behavioral Health Center, as she mentioned. We're both counselors. So, well, I'm a mental health counselor and she's a social worker who also counsels. So, yeah. So today we're just going to touch on a little bit of kind of the mental health side of domestic violence and kind of why sometimes we see those struggles with domestic violence, people that are in it, why they struggled getting the help or wanting the help. And sometimes it can be frustrating as an advocate offering those resources and you're getting a lot of pushback and you're thinking, I've got all these things on a platter for you and they're right here. Why aren't you taking them? So sometimes that can get really frustrating. So we're going to touch on that today. And if you guys have questions, we'll have room for that at the end. So, all right, so this is kind of what we're going to go over today. Some of the barriers that people have leading domestic violence, some of the mental health disorders, tools for advocates to use in the field. We're really going to touch on validation a lot because validation is really important, which I'm sure you guys have all heard that term. But in mental health, validation is really important because what happens when we're invalidated from childhood, even up to adulthood, is you start developing these core beliefs of I'm not worthy, and you start believing what your abuser is telling you. So we're going to touch a lot on validation and invalidation, the core beliefs, a little bit on motivational interviewing, which is going to be a tool for you guys to use in the field. Then Jessica's going to go into kind of the function and the dysfunction, substance use as a solution, because that's why a lot of our folks are in substance use. And then solution focused interventions, the stages of change, and then some of our resources we have here in Southern Utah. Yeah. All right, so I know everybody in here is probably familiar with kind of like that mindset for the victim to kind of feel really, really less than, and they're really devalued. And what happens is over time, that person is pretty much broken down into this little human of a shell. And they start to believe it too. That's part of that invalidation piece. So like it says here, they manipulate, they devalue, they isolate this person from their friends and family, and they make sure that they're completely dependent on this abuser. So by the time I'm done going through so much abuse and so much devaluation, I'm this little shell of a human being, and it's really hard for me to feel like I'm worthy of help. So some of the barriers people face when leaving, so some of the mental barriers, devaluation, manipulation, isolation, that's a big one, because when I've isolated you from your friends and family, you have nothing left. You have nothing left of value. You have nobody on your side besides the abuser. You've got really nothing left. You're just in this isolated area and you have nowhere to go. Invalidation, that's a huge one, which you'll hear me say validation, invalidation so many times, but it's just so huge. So the invalidation piece, if I'm an abuser and I invalidate you constantly, I'll do it slowly at first. And then when I keep doing it, I just get farther and farther with it until I break you down. So if you're a tree and I chop at you a little bit, you get a little couple chunks missing. If I chop at you more and more and more, I'm going to knock you over. And when you're knocked over, you're not going to feel like you're even worthy of help. So comfort and norms. So we talk about it's comforting to stay in the domestic violence situation. It sounds really weird. So it's comforting to stay in that because that's my norm. If I was raised in domestic violence and mom and dad fought and yelled all the time and dad hit mom all the time, that's my norm. I'm used to that. That's fine. And a lot of times folks develop mental health disorders around that. So that goes into more than I'm going to go into, but personality disorders, those are developed from experience. So they're not actually created with, brain chemistry, and that's a whole nother thing. But if that's my normal, I'm okay with that. I'm okay with living in domestic violence because that's what I watch mom go through. That's what I watch dad go through. So it becomes this normal environment and it's almost comforting. So some folks, this is going to sound very bizarre. Some folks find it comforting to be in the discomfort. that is their comfort. And to say you're gonna take them out of that is so scary, and it's just so off-putting. And I have folks that can't even imagine a happy anything. And I'll tell them to like picture, what does happiness look like? And they can't. Because for them, that's their norm and that's their comfort, which it becomes really sad. Childhood exposure, that just touches again on that, like that's their normal, they're used to it and they're okay with being in it, and trying to tell them that there's something different available, they can't even fathom that. Or think that they're worth it. Some of the emotional responses we look at, fear. So fear is really, really intense sometimes, and I'm sure you guys have seen this with some of the folks out in the field or in any of the positions you work in. Fear is pretty intense, and that can really take over that emotional response, and it can prevent me from doing a lot of things. Shame. A lot of folks that feel shame feel they're not worthy of change. So if I feel really ashamed of my situation, I might blame myself. I feel like I put myself in it. I feel like I deserve it because they've told me I'm such a horrible individual and a terrible mom, and I'm just so worthless as a human, then I'm just ashamed to even ask for help. I don't even deserve help. So at that point, my shame is so strong, it just overpowers everything. Humiliation. Why would I admit that I'm stuck in this situation? That's humiliating. Why would I admit that I need help? Why would I admit that I put up with it for this long? Why would I admit that I let my kids stay in this? Why would I admit that I was raised in that? How embarrassing. So a lot of folks, like those emotions are so strong, it just keeps them from reaching out. Let me talk about the resources, which I'm sure you guys are also familiar with. They separate a lot of these victims from their family, and they do it over time. So they do a little bit like, oh, you know, I'm gonna say something negative about your family, something negative about your friends. And before you know it, I'm the only person you have to rely on. So they don't even know that there's other resources out there. And they're dependent on their perpetrator. And a lot of folks have distrust in authorities. Maybe they've reached out before, maybe it didn't work. Maybe they watched mom reach out when they were a kid and that didn't work. Maybe they were taken from mom when they were a kid and they were raised in foster, and then they suffered a whole nother slew of trauma and abuse. And that's because the authorities took them out of that situation. I'm not gonna do that to my kiddos. Why would I do that? That's terrible. Like, that's terrible to even think about. So a lot of them can't even think about what would be helpful and what wouldn't, and they just don't have the mental capacity to kind of separate those. I feel like I'm standing on this side a lot, so I'm just gonna move. So I want to go over a couple of the mental health disorders because we've got a lot of them, and just from this quote, like evidence supports that exposure leads to depression, PTSD, anxiety, suicidal thoughts and attempts. There's a whole nother slew of mental health disorders. There's borderline personality is one that we see a lot. So a lot of dysfunction can lead to the personality disorders, which makes you comfortable in the discomfort and the turmoil. And if I think of something outside that turmoil, it's just, it is out of, it's not okay. It's like if I told you guys to go in the turmoil and you get that, ooh, that's not okay feeling, that's what they get when we tell them that there's something better out there. So some of the symptoms of depression, a lot of people think it's just, you know, being sad, but it is feeling sad on more days than not. So now I'm feeling sad and depressed on more days and less days of happiness. Loss of interest in activities, and that's also going to contribute to that separation. Like I feel more depressed, I'm not hanging out with family. I'm not going to family barbecues. I don't want to go hang out with my friends. I'm missing work a lot. I'm calling in. I'm not talking to colleagues. I'm keeping to myself. Feelings of guilt and worthlessness. A lot of folks with depression they'll blame themselves. Like everybody else gets sad. Why can't I just get out of it? Like they're able to go to the barbecue and they said they're sad. And then family and friends don't understand how intense the depression is. So then they kind of like poke at them like, hey, you're just a little sad. Get over it. Just come on, let's go. It's not a big deal. And then you feel even worse because then you feel really guilty and ashamed. Like, why can't I? Like, this is ridiculous. Everybody else can just pick themselves up by the bootstraps and go, but I can't. So you start feeling really guilty. A lot of people get irritable. Physical symptoms can be a whole slew of things. It can be stomach aches. It can be muscle aches. It can be just feeling unwell. It can be like laying in your bed, feeling like you cannot even lift your arm. Like it is that intense. Like, you know, when you have the flu and your whole body just hurts, like you can't even lift your arm. It can be like that. And then people don't understand. They're like, just get out of bed. What's the big deal? And I've had folks tell me, man, I laid in bed until I just had to feed my kids. And how guilty would you feel if like you have a toddler and you feed them, you take care of them, but then you go back to bed? And like, that's just gotta be a terror, and it's out of your control. It's literally chemistry in your brain that's making you feel this way. And then, of course, thoughts of death or suicide, which a lot of folks keep them to themselves. So I know in our office, you have to build that trust and you have to kind of build that rapport with people to get them to confess to you like, hey, I've been having thoughts of killing myself. And sometimes we have to do direct questioning, and that falls in your guys' duties and, you know, like what you guys are allowed to ask. I know with my folks, sometimes they don't bring it up to me for 2-3 sessions. Sometimes it's months, because they're afraid if they tell me I've had thoughts of killing myself, that I have some men in white coats waiting outside my door and that's it. And now I'm gonna take them from their kids, and I can't go to BMed because they'll take my children away because they think I'm suicidal. And they just think the worst case scenario. And it's not reality, but a lot of folks think it is, so they'll just keep that to themselves. So building that trust and validating that it's okay to not feel okay sometimes is super important. So let's talk about anxiety a little bit. And anxiety is another one of those, everybody has anxiety. We all have anxiety. We all feel nervous. We all get anxious about certain things. And anxiety is kind of telling us we need to plan and prepare for something, right? So if we have anxiety because we're going on a trip to the Bahamas, we have anxiety to say, okay, I need to get my passport. I need to pack all my things. I need to make sure I've got my money. I need all these things. So that's a normal amount of anxiety. I have a test, I got anxiety, I got to study. When anxiety gets to like where you're diagnosed with actual generalized anxiety disorder, it is so much more intense than that. And it's like having these voices in your head all the time. But what if this happens? But what if this happens? What if? And we call that catastrophizing. So these are just the regular symptoms of anxiety: excessive worry most days, difficulty controlling it, restlessness, fatigue. But this is what's going through somebody's mind all the time. So when you ask somebody like, hey, have you ever reached out for help? Or I've got some resources for you. Like, would you like me to connect you to some? This is what's going through their mind. What if somebody finds out? Or what if my, abuser finds out? What if it doesn't work? What if they take my kids? What if they blame me? What if I get in trouble? And this is going through their mind probably in like 20 seconds, like all of that. And we call it catastrophizing. So it just builds one thing. What if, and it just keeps going, and they can't shut it off. And now that's where we go into therapy, and like, that's a whole nother thing, but then we teach them skills and we teach them how to interrupt. Some folks get medication, and there's ways to control it. But if somebody's not getting treated for it, when you're asking them just general questions, hey, I've got these resources, and they're going through that in their head, trying to pay attention to you and think that you're there to help, it's gonna be pretty tough. And sometimes like anxiety is it's just a nagging constant, and you're always thinking the worst case scenario, and because you and I can all think of the worst case scenario, but then we can stop and go, it's probably not gonna happen though, and that's fine. These folks can't stop it, and they can't think it's not gonna happen. So I want to touch on invalidation again, and I know we talked a lot about validation, invalidation. So what do you guys think validation is? Can anybody give me an example of validation?
You're doing a really good job presenting.
Thank you, Jessica. That would be validation, right? What would be an example of invalidation?
You're fine. I don't have to do that.
Yes, you're fine. Yes, exactly. Like, oh, I'm really depressed today. You're fine. Go to the barbecue. That's not validating somebody's feelings. And I don't know what somebody's feeling. I will admit, I've never had depression. So for me, even as a therapist, to be like, you know what, I really know how you feel. I don't know how you feel. So for me to say that, that's really invalidating. Even if I've been through domestic violence, even if I've, recovered from substance use, me saying I know how you feel, so invalidating. And I know people mean well, like they mean well by it, but that.
I'm gonna add in, did you guys
Yes.
notice how hard it was to find a validating statement? And that's because in our society, we don't practice validation. And so we are not practiced in finding validating statements, but we were really, really good at finding all those invalidated. And so it is something very important to practice those efforts of validation, because we are poor at it as a society. And so interventionists like us really have to be practiced in like an obtuse way, so that it comes naturally to us when we need to provide it to our clients and to survivors.
And that brings a good point, because 9 times out of 10, when you ask somebody to validate their anxiety or validate their depression, or, like, they can't, like, to say, like, what's a validating statement for you about your mental health? And they can at a year into therapy, but right when they come through the door, they can't. And most of these folks, when you are so invalidated as a kid, you learn to live with that invalidation, and it becomes a norm for you. So by the time I'm an adult and I've got an abuser invalidating me, that just feels fine. That's fine. It's no big deal. And we teach our folks in like DBT with this, which is dialectical behavioral therapy, but we have groups that we do. And we kind of teach survivors, like, you've almost got like a target on your back, because invalidating abusers can sense that. Because if you were to just shut somebody down right off the bat, when they're mean to you, they're rude to you, they're invalidating, you're like, nope, I don't have time for this. They're going to go to somebody else. They're gonna say, oh, not an easy target, and they're gonna run. And then they're gonna go to somebody else. But somebody who has not learned to validate themselves and feel good about themselves, they just have an open target on their back that says, abuse me. I'm here. Yep, I'm right here. I'm ready to be abused. And it's sad because they don't even know it until you teach them the importance of validation and not putting up with invalidation. So that's something we really, really focus on. And like, I like this picture, this image, because it kind of shows like tiny shreds, because as you're a kid, like, just think about a kid saying, mom, watch me, I jump rope 50 times. You're like, okay. And then like 10 minutes later, right? Mom. And then 1 minute later, mom, watch me. And you're just like, okay, I see it, But what that kid's looking for is validation. And they're looking for you to be like, you know what? You are good at that jump rope. Not like, good job. Yeah, good job. Yeah, good job. Like, but if you say, you know what? You're jump roping faster than you used to. That's validating versus, good job, great picture. I see it, you drew that, but that's validating. And most kids don't get that because most parents don't know how to do it. So if mom wasn't validated, she doesn't know how to validate her kid, just like with domestic abuse, like if they watched it and witnessed it, they're okay being in it and being invalidated. So it just takes little tiny particles and pieces away from you until you're just kind of nothing left. So what consistent invalidation leads to? Self-blame, insecurity, unstable self-identity. That's where we get into those personality disorders. Feelings of worthlessness, that seeking unhealthy validation, that's where we're talking about that target. Because if I was so invalidated as a kid and I never have any healthy validation, I'll take it from anywhere. I'll take that from an abuser. I'll take unhealthy validation where they give me a crumb and then they crush me. Well, that's fine. At least they gave me a little. So I'll seek it from unhealthy sources. I'll seek it from substances, from drugs. I'll seek it from unhealthy crowds, like friends that are not healthy to be around, but they validate me once in a while. So that's great. So you'll just start seeking it from unhealthy sources and not even realize it until somebody points it out to you. Negative core beliefs. So we go through traumatic events like a kid, and you go through like domestic violence as a kid, and you watch this, you witness this, you start to believe these negative core beliefs of that it's okay. That's just okay that that dad treats me like that. Yeah, I probably am worthless. Yeah, dad said like I'm super worthless. So I mean, I probably am. When you hear it enough times, my belief now going into adulthood is that I am worthless. So when my abuser says I'm worthless, you're probably right, I am worthless. So those core beliefs stick with us all the way through adulthood. Yeah.
I have a question. So when you were talking about, personality disorders that kind of branch from this.
Yeah.
What if you're in a situation where the child that hasn't necessarily been abused or neglected, but the parent has one of a personality disorder? Is it something that can be passed on by, I'm just saying, your child learns by watching and seeing?
Yeah, so even if like, let's say mom's got borderline personality disorder and she's not abusive and she's not showing them any abuse or she's not neglecting them, but she'll still pass on those traits because she's gonna be okay with, like, I'll give you an example of like, somebody is okay with being in turmoil. Like, my kid tried to stab somebody last night. It's like, well, it happens. Because that's how they cope. And I know, right? Like we laugh because we're going, man, if somebody told me that, I'd be like, what? My kid, but what are you talking about? But some of these folks with personality disorders, they minimize it to this big so I can handle it. Cause if I blow it up to how big it actually is, like my kid tried to stab somebody, I can't handle that. So I have to make it this big and now I can handle that. That's fine. It's not that big of a deal. At least we know the cops, so it's fine. But then the kids kind of see that unhealthy behavior and then they develop unhealthy behaviors because it's what they're taught. So most of the time, if mom has personality disorder, grandma also did, and then her grandmas did, and they just keep going, even if there's no abuse. Yeah, so personality disorders are learned. And they're just like learned behaviors. They could be interrupted and we can teach them skills and they don't have to be passed on, but if you don't see a problem with it, you don't know to go get help with it. Because that's my norm, I'm good with it, yeah. Personality disorders are super tricky. So more on the negative core beliefs, and these are some that I actually use some examples from, I do EMDR, which is reprocessing traumatic memories, right? So when we do EMDR, we have to come up with a negative core belief and then a positive cognition that you want to believe. So these are examples I've actually had. I'm worthless, I'm not worth believing. That was somebody who came forward about sexual abuse and nobody believed her as a kid. So in adulthood, I'm not worth believing, so I'm not gonna speak up to anything. I'm just gonna say yes to everything. Oh, you wanna do that? I don't want to, but it's fine, I'll do it. Because nobody believes me anyway if I fight back. I'm a failure, I'm a terrible parent, I'll never be good enough. So when you have the traumatic events, you associate that negative cognition with it. But if I have this true belief inside of me that I'm worthless and my perpetrator is telling me I'm worthless, why would I argue? Of course I'm worthless. I've been worthless since I was 8. My dad used to tell me that all the time. So these core beliefs are really, really sunk deep down. And then when we do therapy, it's hard to get them out of there, but we can. And we try to turn them into like positive beliefs. But trying to convince folks of that sometimes is really tricky. Validation again. We like validation. I feel like I say validation like 27 times a day, like, but then my clients will come in and they're like, I self-validated. And it's amazing when they're out of a domestic violence situation. And then they're like, I didn't put up with that because they self-validated. So if I can validate myself, I don't need crappy validation from you. You know what I mean? Like I can do it for myself. But if I can't do it for myself, I'm going to take it from whoever will give me a crumb of validation that is not even worth my time. You know, like that's what happens. So it reinforces that they're not being judged or blamed, makes them feel secure in their perspective, strengthens their sense of worth, creates a sense of safety. So I can't stress this enough. Validation is not agreeing. So if you go to somebody's house and, you know, like as an advocate or whatever your role is, or they come into your office and they say, man, like I have tried to leave 10 times and I just haven't, and I'm just not strong enough or whatever it is. But, you know, I really wish my kids would stop witnessing this violence, you know, and you're thinking in your head, well, I wish they would too, but I'm not going to validate, be like, you know, I agree, you should stay in that. I think it sounds fine. I agree that it's not the time to leave and you should leave your kids in it. Validating would be a statement like, yeah, it sounds like that's really hard. That's it. And it lets them be comfortable in their perspective. It makes room for their perspective without me judging what you're thinking or feeling. Because who am I to judge where I don't know where you're at? Some of the tools in the field that you guys can use or in the office or wherever you guys work. So crisis, de-escalation is kind of tricky because it gets into more of like mental health first aid, like I was talking to Vicki about, where there is some tools, but there's a lot of tools, like it's just kind of deciphering, but some basic ones, a lot of things can be de-escalated with validation. I know that sounds silly, but it's true. Like you start validating like a bully and like just seeing their point of view and just validating, they'll eventually stop because they're not getting to you anymore. So offer support right in the moment. What is it that you need right now? I think I know what you need and I have a whole platter of resources, but that's not what they need. They might need it. Some are like, yes, thank you. Like, give me all that. And then some of them are like, yeah, I just need you to listen to me for 10 minutes. And then I'm going to call you back 17 more times in the next 6 months. And that's fine. But that's what I need right now. Like, okay. And this is a big one, motivational interviewing, and I'm guilty of this. Try not to be the problem solver. Somebody comes to my office and I'm like, oh, this is the diagnosis you have. Like, I know what will fix that. We could do this. And then I drop it. I leave it in my head because I'm not the problem solver. They need to figure out what they need. Steer clear advice giving. Validation, again, we're being non-judgmental. It sounds like this is important to you. It must be very difficult to think about these decisions right now. Makes sense that you're hesitant right now to, you know, reach out for help. And then connecting your resources, that would be like motivational interviewing. Is basically asking for permission. It leaves them with some sense of control when they have no control over the situation. So giving them that is super validating. Like, can I connect you with some resources rather than I have some resources for you, which we all do. I've got a ton. I've got case management, I've got employment. I'm like, hey, here, like, I've got books, I got group, like, come on. But instead it's like, would you be okay with working with case management? This is what they offer. Would that be something you'd like to do? Like, what are your thoughts on creating a safety plan? Have you, and I had that today. They didn't want to make one. Should they? Yeah, I think so, but they don't want to. Like, that's their call. So I said, what are your thoughts on making a safety plan rather than you need to make a safety plan? So it's just giving them kind of that power of choice, and it also gets a little bit of buy-in, or they can trust you and you can start building that rapport. And maybe on that, 10th visit or 4th visit, then they will take those resources. This goes in. Do you guys have any questions? And that's okay too. Do you guys want to validate anything? Jessica brings up a good point. Super easy to invalidate. We can always get a bunch of responses.
Okay, so we're gonna switch gears and talk about substance use and domestic violence. The CDC estimates between 40 and 60% of domestic violence where seeking services report substance abuse as a problem. So 1 out of every 2 people you're helping are going to have something going on with substance abuse. And this is challenging because it creates issues. There's a lot of issues. But one of the things that we have to take kind of like recognize as we are doing interventions is that this is a function for the individual who is using substances. This is a solution for them. And we, as interventionists, view it as a problem, while they view it as a solution. And that is something that we have to be really honest with ourselves. And we need to put ourselves into that empathy space. And some of the reasons that they're using is to promote the financial support from their partner, or their partner actually provides them with their drug of choice. And they have fear, when we are using, we make some really poor decisions. And that your partner, your domestic violence partner, knows the dirty things that you've done. And so it's not uncommon that they'll blackmail their partner. Hey, you leave me, I'm gonna report you to DCFS for this. I'm gonna tell the cops that you smuggled. I'm gonna tell them that you were selling your body for drugs. And they will absolutely leverage their knowledge of the choices that the individual in addiction has done, and create risk for their children. Or get them into legal trouble. I've seen that happen a lot, especially with narcissistic abuse. So again, we talk about substance abuse is a solution to the individual. And so it's so important when we're doing interventions that we look at it through that lens of, all right, what function are they actually getting out of their substance use? What benefit are they actually pulling from this? Why is it functional for them? And we have to put our biases to the side. And that is probably the hardest part of working in substance abuse. I've been doing it now for 4 years. I cannot put my own opinion of a substance or alcohol onto the table of the person that I'm helping, because my life's experiences are not their experiences. And I have to dig in. I have to understand, why are they resorting to their DOC? Why are they going to their substance? And have to open up an empathetic lens to look for that solution. So we take on, in substance abuse, we try to take a solutions-focused intervention. We try to understand from the individual. We're going to ask open-ended questions. We're going to find out, what is it doing? I can't tell you the number of times somebody says, it's too much for me, I'm out, I'm going to go get help. It's a wonderful escape. It is a very effective escape from our emotional experiences. And we cannot downplay that. And they might have pain. One of the unique things that I see with my domestic violence survivors is that they started using to deal with the pain that they got from the abuse They got thrown down the stairs, they got pushed over the banister, now they have cracked ribs, so they started taking opioids. The opioids sure did help with that pain, but sure did help with the emotional pain. And one thing led to another. In the state of Utah, one of the statistics I read once upon a time said about 47% of opioid abusers started on prescription medications. They didn't go out and find their, neighborhood drug dealer, they got it from their doctor, treating a perfectly valid medical condition. Boredom, oh my goodness, boredom. So a lot of our folks, they need a lot of stimuli, they need that adrenaline, they need that excitement. And that is something that is so crippling to deal with when we're trying to help people, find their sobriety and find joy in recovery, is we gotta address this boredom, because life is boring. And when you're like live action and hyped up on meth and everything is, like, sometimes clients will describe their life to me, and I think about that movie Crank. I don't know if any of you guys have seen it, where he has to keep the adrenaline going or else he dies. And I'm like, this is like your life for the last 7 years. They don't know how to cope sitting in their boredom. And so we have to teach them, one, sobriety can be fun, and two, it's okay to be bored. It's okay to like twiddle your thumbs and look for the next thing to do. And often people will use to hide their mental health symptoms. Mental health symptoms are loud. They are disturbing. They can completely derail somebody from being able to function in life. And I have met many, many, many people who use substances because the antidepressants don't work, or the interventions that they've tried to access haven't worked, but the opioid sure does. And so they use it as self-medicating, because the mental health symptoms are very overwhelming. Stress management, domestic violence is stressful. And so they will use substances as a tool to cope with that stress. Withdrawal symptoms, oh my goodness, wouldn't wish on my worst nightmare, or my worst enemy, sorry. I've had several clients in my office actively withdrawing as we're trying to do evaluations and interventions, watching them, holding themselves, cradling themselves as though they are a baby, because they are in so much torturous pain that they can't even breathe half of the time, let alone deal with the issues in their life. Withdrawal is torture. And they will go back to using because it is awful. And then a coping tool to deal with trauma. Again, it's a really effective resource to fight the pain. But we also have to be realistic about the fact that it is a dysfunction. So it sure is effective, and it leads to the ongoing issues. And everybody in active addiction will readily tell you, I have my reasons why I use it, and I recognize why I need to stop. And that's where we use motivational interviewing to help the individual identify for themselves why they need to address their substance use issues. Some places take abstinence only models. Some will use harm reduction models. So abstinence only is no use for any reason at all, no exceptions. Harm reduction model is how can we cut down? How can we moderate our use? How can we limit how often we're doing it? How can we use only when the kids are gone? Is sometimes as good as we can get. And we've got to help the person figure out for themselves what matters for them as they are on their path to finding a higher quality of life. Motivational interviewing, again, like Amanda introduced, that gives them the control and power. And one of the most common themes under substance abuse is that the person goes to the substance because it gives them a sense of control in their life, where they otherwise may not feel any control. And so the motivational interviewing is powerful. To use out into the field especially when we're doing direct interventions, where we can allow the person to find their own path. So some of the examples, tell me what you like about using. They're using for a reason. let's understand, why do you like it? Wait, if I understand why somebody is getting high, now I can ask a whole lot of questions about the dysfunction that's actually coming, even though they've got the reason, right? Why did they come for help? What's different this time? What brought you in today? Oh my gosh, that's always my number one question. Anytime I see anybody, what brought you in today? You're gonna guide me. We're gonna let you take our conversation wherever it needs to go. What did you think, or what do you think you're gonna lose if you stop using? And I will tell you, people fear quitting. That is that one crutch that gets them to be able to wake up and take their kids to school after being up for 4 hours, having their partner screaming in their face and chokeholding them. That is one of the realities of what we face when we are dealing with the realities of domestic violence. They really will guide you with motivational interviewing and understanding what exactly their experience is. Tell me why you think you're gonna be successful finding sobriety. If you don't have a substance to fall back on, how are you gonna manage your stress? These are really, really important questions that the individual needs to know for themselves. And we cannot impose answers on them. Our answers are not their truth. So motivational interviewing helps guide us to something that we can actively use as a tool. So when I did case management for the first 10 years of my career, I used stages of change all the time. And the biggest reason is because pre-contemplation is the son of. So stages of change are pre-contemplation, contemplation, preparation, action, and maintenance. And this is a cycle. And anytime we're making any difference in our life, we go round and round and round and round. Well, unfortunately, we got that number one, which is pre-contemplation. And it is the most frustrating part of change for interventionists. Because the client comes in, they have a big issue. They start to recognize maybe change. They're not actually willing to do anything about it. And we feel stuck and we feel frustrated and we start to transpose that onto them and we get some counter transference happening and we start to get burned out and we start to feel frustrated. So I want to give you guys some tools about the stages of change. So pre-contemplation, this is the most frustrating stage. First, we are raising awareness of the problem in a non-judgmental way. This is where validation comes in. We want to emphasize the possibility of change. We want to emphasize what the person's strengths, what their goals are. All that motivational interviewing that we did is going to give us what we need to be able to, hey, yeah, couldn't it be awesome if you didn't have to wake up with a hangover? Could you imagine not having to shoot up every day? Wouldn't that be something amazing? Oh my gosh, what if you were to get your kids back in your home? How great would that be? So it's these kinds of questions that we take from motivational interviewing and then we start to plant these seeds. Couldn't it be nice? Number two, safety plan. We need to help them raise their awareness of what substances they're actually doing, what dysfunction are substances actually creating in their life. And so we ask them, what would you think about doing a safety plan? The next time you use and you're coming down and you're worried about neglecting your kids, wouldn't it be nice if you had a plan in place so that you have steps to take with them? Safety plans make us feel validated too, because we actually feel like we're doing something. And so that's kind of a burnout protector for ourselves too, on a professional level. Or risk planning as well. Safety planning for, okay, next time your partner gets violent, what are you gonna do? And they're not gonna get out of it yet, but we can at least talk about what they can do when it happens. Third thing, help the person make links between their substance abuse and the violence. So as we're doing motivational interviewing and they're talking to us about some of the things that they have going on, and you know, they're sharing, so I'll give you an example. Oh, so you started using, and then your partner said that he's not going to give you any more supply unless you go pick up the batch from Las Vegas. And so you ended up going and drugging you on. And when I brought this to my client's attention, they were like, he did have me drug me on. Giving a name can be so powerful for an individual. And so helping them make that connection between their actual use and the violence that they're being succumbed to can be such a powerful thing. And substances being used as power and control. I had one client tell me, I've been addicted for 6 months longer than I even wanted to. And I said, well, how does that happen? What do you mean by that? And she said, well, every morning, my husband would wake me up 7 o'clock and he'd shoot me up with meth so I could get up and take care of the kids. And then I'd come home, dropping them off 9 o'clock. He'd shoot me up with heroin. And that makes a really vulnerable cocktail. And he would engage in some really violating behaviors like that. Every single day for 6 months. He ended up getting arrested and so at that point, she was able to come down and seek help. But for 6 months, she was held chemically hostage because her husband kept shooting her up with a drug cocktail. So sometimes the client needs to kind of have their awareness brought to the fact that the substances are the tool of power and control. And then provide local resources without judgment. I normalize MAT treatments, those medical assisted treatments, to the end of the world because they are effective, because they offer a pathway out of illicit substance abuse. Fentanyl is the #1 substance that we're overdosing on, and it's coming from street drugs. If we can help somebody with methadone so that they can get engaged in treatment, so they can get away from the fentanyl, we're saving a life. And so we have to kind of look at what are we actually doing for our folks to help save their lives. Contemplation phase. Change would be nice. I wonder what that would look like. That's where we start to get a breath of fresh air. Like, okay, something can happen. But we can still feel really frustrated here because they're just thinking about it at this moment. So we want to normalize ambivalence. Ambivalence means going one way or another. Sure, it'd be nice to be sober, but I really like getting drunk. These are two truths. This is the dialectic of substance abuse. On the one hand, they hate that they use. On the other hand, they love that they use. And because we're humans, we get to experience lots of emotions at exactly the same time. And this is so normal that our folks are going to have a lot of ambivalence about their substance abuse. So we normalize it. And that is the phrase I give every one of my clients. You're human. You get to feel a lot of emotions all at once. That can be earth-shattering for somebody. And then when we help them have comfort with their ambivalence, we can help them identify their pros and cons. Again, going back to that motivational interview. Why does it matter to you whether substance abuse is part of your life or not? We emphasize the free choice, the responsibility, the ability for change, control. Oh my goodness, that is what substance abuse is about. So helping them find their control. Helping them find their control in literally basic decisions like which shoes are you going to wear today can be empowering for somebody who has been under the thumb of somebody for a period of time. Mirror your client language when you're in contemplation phase. If they are telling you that, you know, I'm sick of getting high, I'm tired of being hungover all the time. Oh, okay. So you're sick of getting high. Oh, you're tired. You're exhausted. You don't want to be hungover all the time. We're going to mirror that because it validates. And then it shows them, they've got a teammate. There's somebody who aligns with that, who gets them, who can see the world how they see it. And it's going to get buy-in. So we're also going to talk positively about the agencies. Amanda touched on this, that a lot of people in domestic violence situations are terrified of police services. I'm not dealing with DCFS, so I can take my kids. I spend so many hours out of my week talking to my folks about how wonderful DCFS is an agency. And you know what though, I believe it. This isn't me just BSing them. One, because DCFS is inevitable. But it really is a powerful agency. And so I talk to my clients about, listen, we're doing society all wrong. This whole single mom thing, raising 3 kids for the birds. We've never done this in history until the 1950s. We need a village. We need to surround ourselves with groups of people who care about us. And that's what DCFS is. It's social. It's people who want to help you. So if you want change and you want something good, they're going to connect you with resources. They're going to pay for your therapy. They're going to pay for your kids' therapy. They're going to help pay for education stuff. They're going to help you pay for transportation. They're going to help you pay for brand new interviewing clothing so you can go get a job. They're going to pay for drug testing. They're going to help you get through the courts. If you actually want change, DCFS can be life-changing. And getting that buy-in, because I genuinely believe it too, because I've watched hundreds of women use DCFS for its strengths and be able to completely change their lives. Go get college degrees that financially self-sustainable. Go get into a house so they can live independently with their children in ways that they've never been able to do before. So we need to get agency buy-in. And it's really important that we know the strengths and the powers of our agencies. It's getting people therapy. It can be like the mountain to surmount. Why? You ask yourself as an interventionist, why do I like this resource? Why do I think it's beneficial? Why do I think it can benefit this person that I am actually consulting? And get the buy-in with yourself first so that you can really push how beneficial these agencies are. And then preparation phase. I want to make change. What do I need to do? This is where we get excited. This is why we have our jobs. Right? This is why we care about what we're doing. Because this is when the magic actually starts to happen. They start to get their plan. They start to find their resources. They start to build their village. They start to build their community. So we want to validate, we want to acknowledge the significance of choosing to seek treatment. We want to validate that they have the ability, despite everything that they've gone through. We're going to help them find their own strengths. We're going to actually like literally ask them, what makes you powerful? Why are you going to be good at this? And they're going to rely on their strengths as they make this choice to actually show up for the meetings. And actually attend their therapy sessions, and actually show up for the court hearings. Suggest choices for action. Now we can start to let our expertise come onto the table, because they may not have ideas. And so we can actually make the suggestions. We can let the survivor decide what is best for them. And we can really highlight the appropriateness or the achievable level of taking the path that they want to take. And that is so validating. I think I want to go to the Dove Center. Oh my gosh, let me tell you what the Dove Center can do for you. And they get jazzed, they get excited because we have buy-in. Yes, exactly. Yeah, nothing gets me more excited than when somebody's like, that change phase, like, let's do this. We want to discuss their fears and their worries, and we want to normalize it. We're not negative because we have worries. We're not going to fail because we have fears. This is part of the reality of the anxiety of making change. And so we want to talk about it. We want to help the individual find the positives, the silver lining in the challenging decisions that they are making. And if they are fearful, suggest that they visit the therapist, get to know that. Suggest that they go to where they're going to get the treatment. Go sit in on a group, go have a conversation first, go toward the building. If they are feeling, like they just can't quite pull that trigger, so to speak, help them dream up ways where they can make it feel more welcoming and more comfortable for them. And that really promotes it. We move on to action. I know what I need to do, and here's what I'm doing. And we ask them, motivational interviewing again, what's going to hold you accountable? How often do you want me to check in on you? What do you need to be successful? And how can I support you with that? And then maintenance. I made the change, now how do I do it? How do I sustain it? And this is a cycle because we like the big dream of like, I'm gonna put them in treatment, they're gonna get clean, they're gonna be clean for the rest of their life, but you know that's not. They come into treatment. And we say, hey, what's your goal? And they're like, I wanna wake up in the morning before noon. Okay, that's what we're gonna do. Let's figure out how we can get you out of bed before noon every day. And that's what they're gonna work on. And we're gonna go through this whole step. And then we're gonna start over again. Hey, what's your goal? I wanna do my laundry every week. All right, that's the goal. This is what we're doing. And we're gonna get hyped and we're gonna be cheerleaders every single time, even though most of the time change is small. Yeah.
It almost sounds like they're reparenting them.
Super, very much, absolutely. Because again, so much of what brings us into domestic violence is chronic invalidation. Because we as a society do not know how to validate it. So most of us were not raised in highly validating environments. And we are absolutely helping them learn how to parent that core of a child. I always ask people, hey, you spent, good 14 years as a child developmentally. Where did that child go? Did that child disappear one day? Absolutely not. Just like a tree, our child is that sapling, the core within us, our core beliefs, our core philosophies of the world come from the child that is still within us as we speak and breathe at this very moment. That child who is abused, neglected, invalidated, ignored, dismissed, mistreated, she's still there. She still has all of that ouch. And she needs loved, and she needs comforted, and she needs validated like crazy. And we need to love her so that we can love outside of us. And we like to think that we grow out of childhood and then all of a sudden we're magically adults, but we still have our child within us all the time. And so, yes, you have a very valid point. We are teaching our clients through all of these stages of change how to parent the child in a really healthy way, because they were often not taught how to do that. So then I just wanted to touch one last point, and that is the challenges of motivational interviewing, which are the 5 R's: relevance, risk, rewards, roadblocks, and repetition. Motivational interviewing is one of the most powerful tools you can use to connect with a person to make meaningful change. And it's really, really hard because it's frustrating as a clinician, right? As an interventionist. And so making sure that you're aware. So relevance, encouraging your individual to indicate why quitting is personally relevant to them. You've got to find that person's relevance. So as I'm asking questions, I'm seeking relevance. Risks. Ask the patient to identify the potential negative consequences of the substance use and the potential negative consequences of quitting. Rewards. Ask the patient to identify potential benefits of stopping substance abuse. Why does it matter? Roadblocks. Ask the patient to identify barriers or impediments to quitting. I will tell you that list of why they can't quit is always going to be longer than the reasons that they want to quit. But I will also tell you the reasons they want to quit are always so much more powerful than the reasons that they want to be prison. And helping them identify that themselves. And then the hard part of using motivational interview, it's repetitive. And I'll meet with somebody this week and we'll have a big breakthrough. We'll have like this big and you meet with them next week and you'll be like, hey, what did you do? Oh, I gotta figure it out. Cool. Let's start over again. And giving them the motivation, giving them that support, giving them that validation. We have to soothe ourselves. We have to remind ourselves that this is really, really hard work we're doing. And when we do feel blocked, when we do feel frustrated, it's okay that we're feeling frustrated. And there really are tools that help make this process a lot easier. And check in with that countertransference. Countertransference is when something comes up and you're intervening and you're feeling it. You're feeling it. You also got neglected as a child. You also saw your parents getting beaten up. You also know the effects of substance abuse, and they're talking about it, and you're feeling it. Listen to it. It'll guide you. Don't let it motivate your choices. Don't let it influence how you are interacting. But it'll influence your intuition so that you can help guide your individual to where they can find healthiness, where they can find help. Okay, so don't completely dismiss that countertransference, but always recognize it with caution. I think that was it. So we got, we were talking about what resources to provide because we know what's going on the internet. And we decided we're just gonna highlight the Southern Utah ones that we have all here in person. And we're confident you guys are quite aware of many of the resources that we have. But we just wanna highlight our agency does therapy from 0 to 110, and we have all sorts of interventions. We work with DCFS, we work with Medicaid. We are a really great resource to get people in a meaningful way. The Dove Center does beautiful interventions with groups, with therapies. They can help financially. They can give somebody a safe place to be. The Family Support Center, this is an underutilized resource. The Family Support Center will watch children for up to 2 hours for free. If the parent, with Medicaid, if the parent is seeking treatment. That is powerful. Somebody had a hand back there?
For your groups, are you have virtual?
Some of our groups are virtual, so we do DBT groups virtually. None of our substance abuse groups are virtual anymore. But we are having negotiations about whether we're going to address that or not. The issue is, in substance use, the number one rule, substance abuse treatment, gotta show up. Gotta show up. That is how we recover. And so the issue with offering virtual substance abuse treatment is
We don't have to show up.
people don't have to show up. They're at home in pajamas, they're comfortable, they're being complacent, they are not putting effort into the stages of change that they're engaging in. And we do not find highly successful outcomes. But we also, in our 5 counties, have a very curious challenge with rural folks. And one of the big barriers that we contend with often in our center is how do we get people into town from Tuckerville, from Apple Valley, from Hillsdale? How do we get people to the center so that they can get the treatment that they need? And it is a huge, transportation is the #1 plague in social work. And it is a real issue. And so, yeah, so currently Southwest does not do virtual groups because the outcomes are not very successful. But DBT is, and DBT is very substance use friendly. So keeping that in mind. So if you have somebody who needs to attend virtual groups and they really do need substance abuse treatment, but they can't access, getting them a referral to attend a DBT group is so effective in getting them tools and skills so that they can build what they need psychologically to address their addiction. And it often can be done in a virtual capacity. So keep that in mind as
One
your.
more point, Jessica, too.
Yeah.
So we also at Southwest Behavioral Center, we offer online and virtual counseling. So we'll have you come in for an evaluation in person, but then we can meet with you over Zoom or over the telephone.
Yeah.
So when transportation is an issue for a lot of folks.
Yeah, it is quite common that we do
Yeah.
virtual therapy sessions. It's not a favorite. We'll be candid about that. It is more effective when you're sharing air with somebody, but we'll do it. Meet the client where they're at, meet them where they need. I have one salient to this conversation. I have a woman I'm working with. She's got 5 children. She escaped a domestic violence situation. And I've been doing treatment with her over the phone for a year and a half. Because she can't leave her 5 kids and she's scared of her own shadow half the time. And so she, some of that agoraphobia that comes out. So we're gonna do therapy in the home. That's totally fine. And we're making progress. So The Crisis Stabilization Center is kind of fresh to our community. It is really important. We have BMED, we have the Access Center, and we've got the Crisis Stabilization Center. And since people often don't know the difference, I'm gonna tell you the difference. So BMED is when somebody is suicidal actively. They are self-harming to the point that they are actually causing damage that needs to be sutured or attended to in a medical capacity, or they're in active psychosis to the degree that they need medication to bring themselves back to reality. BMED is the appropriate resource for that. Access Center, maybe somebody is having a panic attack, maybe they are dissociated so hard that they're catatonic. Maybe they're having just having a freak out and they can't regulate themselves. And we're not sure if it's gonna need to be escalated to a medical need or not. We'll take them to the Access Center because the hospital can make the determination. If your client is turned away from the Access Center and their family or loved ones do not want to take them home, that is their sign to take them to the Crisis Stabilization Center. Because the Access Center is only saying this is not serious enough to go to the hospital. But if it's too much for the caregivers, the Crisis Stabilization Center is our third tier. And that is where you can take people when they are, maybe not feeling safe at home. So they're feeling suicidal, but they're not acting on those thoughts. And so they can go to the Crisis Stabilization Center to feel safe. I had somebody who was in a bipolar manic episode and she did not trust her decision making. And so she drove herself to the Crisis Stabilization Center and spent 3 days there while she figured out how to get her manic episode under control.
Sometimes deem whatever they deem as a crisis, like if it's a crisis for them, I just kind of encourage them to go. Because if they feel like they're not safe at home and they can't handle whatever their idea of their crisis situation is, or nobody needs to be arrested, but we don't need to be together, that's where that Crisis Stabilization Center comes in handy.
Yes. So, and then for their families, for intervention, if they don't want to call the police, but they want intervention. And they can't do violence. That is one of the things with the Crisis Stabilization Center. They have zero tolerance for violence. They will call the police at the stabilization center. But they're like, man, I can't handle this family member. They're too much for me. I'm gonna call the police. They can deal with it. The MCOT can come out, the mobile crisis team can come out. Or they can take them to the Crisis Stabilization Center and have them level out there. It's really underutilized right now. And it's such a powerful resource. If the Crisis Stabilization Center gets somebody through the doors and they're like, this person's in active psychosis, you need to take them to the hospital, they will be really candid up front. So when in doubt, it's never a bad thing to just show up at the Crisis Stabilization Center and they will redirect when necessary. But the most powerful part of the Crisis Stabilization Center in our domestic violence populations is it's free. There's absolutely no cost ever to the family, to the individual to use Crisis Stabilization Center services, whereas the Access Center and BMED are extremely costly. And so it gives our folks somewhere they can be that is not going to cost them.
And I don't know if I should throw this out there, but you were mentioning like, so sometimes they'll help with transportation. They have resources because a lot of folks will not want to go out there because it's all the way out in Hurricanes by the DMV and they're like, what if I go out there? How am I gonna get back? And they do have grants and funding to help folks get back home. So they're not gonna open the door and say, hey, get home, you're on your own. They won't. They will help that person get home.
Sherry at the Crisis Stabilization Center, she's the director over there. She doesn't necessarily want the public to know about the transportation money, but she does want professionals to know that there are transportation monies available. So that if your client, when you're doing an intervention and you need to get them connected resources, and they have a transportation barrier, there is a resource for the Crisis Stabilization Center to overcome that. And then of course, switch points. They offer absolute expertise. I have seen them help people get housed who have been homeless for 20 years. I have seen them help people find birth certificates that are so deeply buried that they haven't been able to get one in their entire adult life. I've seen them help somebody who has never issued a birth certificate get verification of birth. so that they could get onto federal supports. And if you're not aware, a lot of federal funding does not allow the individual to take advantage of it unless they have a social security card, a birth certificate, and a driver's license. And that is a huge barrier because one of the common themes of domestic violence is the perpetrator takes all of their identity. So when they're fleeing, they have no idea. How do you get a driver's license if you have no birth certificate, no social security card? And SwitchPoint is expert class at helping people get documentation. And then also finding all the different housing opportunities, finding grants, using Pike counties, things like that. So we use SwitchPoint like crazy to help some of our toughest cases because they're so effective. Okay, I'm over time. I apologize about that. That's the end of our presentation. Do you have any questions, concerns, disagreements?
Thank you so much,
You're
Jessica
welcome.
and Rhonda. That's crucial information, and so thank you so much. I just really appreciate your guys' time for being here. We'll break for lunch and come back at 1.
So, okay. This is like the, I remember just.